It's Pete Voorhees from Atrium Health Levine Cancer Institute in Charlotte, North Carolina. And I am here at the International Workshop on High-Risk Multiple Myeloma. And with me today is my good friend and colleague, Holly Lee from Calgary.
Hi, my name is Holly. I'm a clinician scientist from University of Calgary in Canada.
Very good. So Holly, you and your team in Calgary have led the charge as far as identifying mechanisms of resistance to T-cell redirecting therapies. You want to give us a bit of an overview as to kind of what you guys have gleaned from the research that you've done in your lab?
Yeah, of course. So the main focus of our research is really trying to understand what are the different mechanisms of resistance. And of course, there's tumor-intrinsic, T-cell, tumor microenvironment related factors. But the main focus of our research has been understanding tumor-intrinsic factors. And primarily, especially in the setting of acquired resistance to bispecifics, it appears to be hinging on antigen expression and antigen escape. So across BCMA and GPRC5D targeting bispecifics, we're seeing antigen escape rates of around 60%, 60-70%. And that comes in various forms. Studying that genomically, we see that it's either copy number losses, but perhaps more frequently retained expression of the molecule on the cell surface, but with a mutation, so altering the target epitope. So yesterday in our session, we had a great discussion about how that could lead to functional impact and kind of differing sensitivities to different anti-BCMA and anti-GPRC5D targeting agents that we have. But of course, the discussion went beyond that into a discussion of T-cell related factors as well as tumor microenvironment factors by the other presenters.
Yeah, no, incredible work. Do you want to speak to, any potential differences, in this phenomenon of antigen escape with regards to CAR T-cell therapy, BCMA and GPRC5D directed CAR T-cell therapy as opposed to bispecific antibody treatment? Yeah,
so what we're seeing is that for CAR T-cell therapy, the rates of antigen loss seem to be relatively lower, and it mainly comes in the form of biallelic deletion, so complete loss of the antigen. I believe for BCMA, that's about 5%. For GPRC5D, perhaps more frequent. And bispecifics, it's predominantly mutation-based antigen escape that we're seeing. There is also a distinction between BCMA and GPRC5D. So for BCMA, again, it's that retained surface expression with epitope change. But for GPRC5D, a lot of the mutations that we've cloned and tested in vitro are showing just entrapment of that mutant protein within the cell, so it never comes up to the cell surface.
Yeah, no, absolutely. So with all of that in mind, for a patient, relapsing, who is fit and potentially eligible for CAR T-cell therapy, based on the work that you and others have done, any thoughts about optimal sequence as far as CAR T-cell therapy followed by bispecific antibodies versus the other way around?
I think we're learning that if you're exposed to BCMA bispecific and you get any kind of subsequent immune-targeted therapy, the response rates tend to be lower and suboptimal compared to patients that are completely naive and get it for the first time. And that's with respect to both the depth of response as well as the duration. So perhaps that is partly explained by the biology that we're seeing with these antigen escape. But also, again, I don't want to completely ignore the fact that there's T-cell fitness as well as durability, the tumor microenvironment. I think all of these factors do play a role. So in terms of how we sequence and even combine these therapies, I think those factors all need to play a role. And that's also where the genomics and the functional studies come in, to be able to really understand the biology that underlies these subsequent response durations and depths.
Yeah, no, absolutely. And I think, as we kind of move forward into this whole new domain of T-cell redirecting therapy, I think it's going to be critical that we start doing whole genome sequencing on our patients, who are relapsing after CAR T-cell therapy or after they've received bispecific antibody therapy, to determine what the deletion status is, what the mutation status is, and what sort of a candidate they are for subsequent, repeat BCMA targeted therapy, for example.
Yeah, so, exactly.
Incredibly important work. Now, based on the work that you guys have done, and the 60 to 70%, presence of antigen escape for folks that are on bispecific antibody therapy, obviously the from a clinical research perspective, the obvious thing to do is to target multiple tumor-associated antigens. And in that regard, we had the opportunity at our center to participate in several, I think, very important clinical trials that are ongoing. One is the Redirect-1 study, which is a study that's looking at the combination of the BCMA bispecific antibody teclistamab in combination with the GPRC5D bispecific antibody talquetamab. The initial phase 1 dose escalation occurred in Europe, but then subsequently was expanded, into other regions of the world, including the United States. And to make a long story short, at the recommended phase 2 dose, they saw a very impressive overall response rate of 80% with the combination, which is better than one would have expected, with the 60 to 70% response rates that we typically see with one or the other used alone. Mm-hmm. And I think, very early days, but the duration of response and progression-free survival that we're seeing with the combination is quite remarkable. During the phase 1 dose escalation, it was very intriguing to see the signal of activity in patients with extramedullary disease, mm-hmm. where we know those patients aren't going to do as well with a single agent bispecific antibody-based approach. Mm-hmm. So there was an expansion cohort that was introduced into Redirect-1, looking specifically at patients who had true extramedullary disease, not paramedullary disease. These are myeloma tumors completely outside of bone. Mm-hmm. And what we've seen in that cohort of patients, which was 90, really quite a remarkable effort in a difficult, to treat patient population. Overall response rate, again, was around 80%, but more importantly, the median progression-free survival extends, well beyond a year, which is far better than what one would expect with just a single bispecific alone. So it really kind of gets at this idea that, tumor antigen escape is real, and multi-antigen targeting is really a promising way forward to kind of get around at least that aspect of resistance. So, and I think that the other, very interesting sets of data in the clinical domain as far as multi-antigen targeting is in the trispecific antibody space. So we have, the J&J GPRC5D BCMA trispecific antibody, which at the recommended phase 2 dose in patients who've not received previous BCMA targeted therapy yields a response rate of 100%. And the 1 year progression-free survival and duration of response is, well over 90%. So we're really, we're starting to feel the tangible benefits of what you and others have uncovered in the lab. And then lastly, as far as another very interesting trispecific antibody is one that's targeting both CD38 mm-hmm. as well as BCMA. Mm-hmm. Now, when this first came along, I was thinking, gosh, targeting CD38, that's going to be a bit challenging.
Especially after DARA. And
yeah, exactly. Yeah. And with DARA, we now have evidence that tumor antigen escape with CD38 targeted therapy happens as well. So. Mm-hmm. But not only that, but the fact that CD38 is expressed on, more, lineages, mm-hmm. than just the plasma cells. But, really quite remarkably, when you look at, the phase 1 dose escalation phase of that study, at dose levels 3 through 9, you're seeing, again, overall response rates approaching 80%. And this is a very heavily pretreated mm-hmm. patient population, with many of the patients in the study having received prior BCMA targeted therapy. So you would have expected this group of patients not to do as well as they did. And some of them had even had talquetamab, GPRC5D targeted bispecific antibodies. So it'll be really fascinating to see how that agent moves forward in the clinic. Yeah,
I think it's a really exciting time in myeloma, as you said, and with these multiple agents coming in at different time points of the disease phase, as well as you mentioned, in newly diagnosed, relapsed refractory, and more terminal. And so I think, we're at a really exciting time, and I think there's a lot to understand about translating these clinical benefits into understanding how they're happening with the biological side, and then kind of putting it all together to see if we can really achieve that cure.
Yeah. No, absolutely. Just one last question. So, obviously, targeting, multiple tumor-associated antigens appears very promising in early looks at the data, but, at the end of the day, that's likely not the only reason for resistance to these T-cell redirecting therapies. Mm-hmm. So how do you see the field, in addition to targeting multiple antigens, how do you see the field moving forward so to overcome intrinsic resistance, that we see with some of the bispecific antibody therapies? Again, your response rate 60 to 70%, so 30 to 40% of these patients don't respond right from the get-go. Yeah. And then, acquired resistance in many cases is due to antigen escape, but again, 30 to 40% of the time it's not. So what are your thoughts about how the field will look like in the next 5-10 years?
So I think, we also look outside of the tumor. I think there's a lot of focus and interest in looking at tumor microenvironment and then the T cells. One of the presentations yesterday was talking about immunogenic cell death, that even though we're targeting BCMA or GPRC5D, maybe the subsequent and kind of the expanding immune effect is there may be antigen spreading and more epitope, other epitope-related immunity that may be at play. So I think there's a lot to learn in terms of mechanisms of how that initial response happens, but also how it spreads. And for those patients that are primarily refractory, I think we can't ignore the disease burden aspect. Patients who have the very high proliferative and high-risk disease up front, maybe they're the ones that are having poor effects. So there is a unmet need in terms of targeting those patient populations more effectively, again, with different combinations or sequences. So I think that's where the field is also headed, and we should also look further into.
Yeah, I could not agree more. With progress comes many questions, but it's really an exciting time in the field of multiple myeloma, and very hopeful for patients. So thank you for the work that you do on the lab side of things, and we will keep pressing forward on the clinical research side of things and continue to make progress for our patients.
Great, thank you very much.